potentially greater safety, which came out from the clinical trials, as you may recall, with almost 40% reduction in the risk of major bleeding events with the use of direct oral anticoagulants. So this was really the basis for a major change. I would say that for the management of venous thromboembolism, in our medical history, we had two major changes. One associated with the introduction of low-molecular weight heparin, which of course made a great impact in our management of venous thromboembolism, thanks to the fact that the low-molecular weight heparin did not require laboratory monitoring, and the direct oral anticoagulants really represent the second major advance in the management of venous thrombosis. And in fact, since the mid-10s years, so over the last 10 years, more or less, all guidelines have started to recommend direct oral anticoagulants initially as an alternative to vitamin K antagonist for the management of patients with venous thromboembolism. And then the direct oral anticoagulants have become the treatment of choice, the first treatment of choice for patients with venous thromboembolism, thanks to the subsequent availability of post-marketing studies. So we do have the European Society of Cardiology guidelines focusing on pulmonary embolism, which strongly recommend the use of direct oral anticoagulants as a first choice. The American Society of Hematology, which are a little bit more cautious. It's a matter of wording and methodology of the guidelines, but still recommend DOACs over vitamin K antagonists. And the most recently published American College of Chest Physicians guidelines, again, provide a strong recommendation based on moderate severity evidence in favor of the direct oral anticoagulants. And this is really what we do in our clinical practice for the large majority of these patients. As I mentioned, the results of the phase 3 clinical trials were substantially confirmed by many post-marketing studies. This is one of the largest observational studies that we have available, Garfield VTE. That's included all patients with venous thromboembolism, more than 10,000 patients enrolled in several countries around the world. And when the two main treatments, namely vitamin K antagonists and direct oral anticoagulants, were compared using the propensity score matching analysis, you can appreciate a reduction in all-cause mortality in patients receiving the direct oral anticoagulants, a trend to reduction which almost meets statistical significance in recurrent VTE, a reduction about 24% reduction in major bleeding, which is not statistically significant. So substantially, these results confirm the possibility to largely use the DOACs for the majority of patients. Of course, these registries are important because in these studies, many patients that would have been excluded and that were excluded from phase 3 clinical trials were eligible by definition, so much larger and broader population enrolled in these studies. I want to go back to the randomized clinical trials for a second, because one of the concerns that we all had at the beginning was to use an oral agent from the very beginning without any leading parenteral treatments. Actually, the Amplify study, as well as the Einstein studies with rivaroxaban, allowed up to 48 hours of parenteral drugs, so patients could have received 1 or 2 days of parenteral drugs. But with this in mind, I think it's always good to remember how well the direct anticoagulants in the so-called single drug approach went. You see here apixaban is in blue in the Amplify study, and you see recurrent venous thromboembolic events during the first week and the first 3 weeks. There are absolutely no signs of concern in terms of recurrence, so highly effective. But what is really striking is that when you start treatment with a direct anticoagulant such as apixaban in this single drug approach, and you compare the incidence of major bleeding with the overlap between low molecular weight heparin and vitamin K antagonist, you really see a important reduction in terms of major bleeding, which does reach statistical significance. It's an 80% reduction. So we should definitely not be concerned about the single drug approach when feasible, because we do have much to gain, in particular in terms of safety. For apixaban, post-marketing results were extremely encouraging, in particular, and you can see here in a large population of patients from the US, more than 35,000 individuals, and you see that there is a reduction as compared to warfarin in terms of recurrent VT and major bleeding, including gastrointestinal bleeding, that for some of the other dogs has been an issue, because the only problem that was detected in some other studies was an increase in gastrointestinal bleeding, although major bleeding overall was reduced. But here you see definitely no signs of concern. So quite reassuring results for apixaban in this study. And this more recent paper coming out again from the United States, comparing apixaban and rivaroxaban, the other drug that is given with a single drug approach, supports. Of course, both drugs are extremely effective and safe, but there were fewer events, both in terms of recurrent VT and in terms of major bleeding in patients receiving apixaban as compared to patients receiving rivaroxaban. Of course, all these comparisons from observational studies need to be taken extremely carefully, because these are no randomized controlled trials. So it's not easy to adjust for all confounders. So this is a sort of exploratory analysis that does not account as a direct comparison between the two drugs, and we know that there are no randomized controlled trials that have been completed directly comparing the two drugs. But still, I think these are quite reassuring results and information. So for most patients with deep vein thrombosis, as well as pulmonary embolism, direct anticoagulants have become the standard of treatment. Of course, this does not apply to all patients. We know that there are some absolute or relative contraindications. For example, severe renal insufficiency is a contraindication for all direct anticoagulants when creatinine clearance is below 15 milliliters per minute, whereas for the bigatran, this goes up to less than 30 milliliters per minute. Great caution absolute contraindication in the presence of severe liver failure in patients with liver cirrhosis, child C. All direct anticoagulants are contraindicated, whereas rivaroxaban is also contraindicated in patients with child B liver cirrhosis. And then we have subsequently learned from a number of studies and meta-analysis that the direct anticoagulants should not be used in patients with antiphospholipid antibody syndrome, certainly when there is a triple positivity for antibodies, because these drugs have been shown to be less effective, in particular in preventing arterial vascular events than vitamin K antagonists. So this is another area when the DOACs should not be used. And of course, we then have pregnancy and puerperium, where the direct anticoagulants cannot be used. And there remain some issues with some drugs that may cause major interactions and then cannot be used with the direct anticoagulants. But of course, these are some areas that we always need to take into account. But for all other conditions, direct anticoagulants again are and represent the standard of choice. Now let's try to figure some conditions that Mary may have, which do not represent a contraindication to the use of the direct anticoagulants, but may require some additional caution. Let's say that Mary has a moderate renal dysfunction because when she's diagnosed with deep vein thrombosis, actually her creatinine clearance is 35. Sorry, this is milliliter per minute and not milligrams per deciliter. So it's a typo, but 35 milliliters per minute. And I do have a polling question for you. So my question for the audience, and you can then vote and select one of the four options, is what if Mary has had moderate renal dysfunction? And your answer, possible answers include: I would not change my therapeutic strategy, I would still prescribe direct anticoagulant, and I would keep the standard dose. Or I would prescribe direct anticoagulants at lower doses, or I would prescribe unfractionated heparin and warfarin as a better treatment option for Mary, or I would prescribe low molecular weight heparin and warfarin. So you have some time to vote and see what you would do if Mary had moderate renal dysfunction. And of course, I will ask then to have the results of the vote, which will be shown to you in a few seconds. Thank you. So we don't have a strong majority of votes, which is interesting. So I think this will have to be kept in mind during the discussion. So almost half of the respondents would not change their therapeutic strategy, and they would prescribe direct anticoagulants at the standard dose. Almost 40% actually would reduce the dose of the direct oral anticoagulant. 10% would switch to unfractionated heparin and warfarin, and 5% low liquid heparin and warfarin. I don't know if any of the panelists would like to comment on that, or if they would agree with the majority of respondents that they would not change their therapeutic strategy. Anyone wants to comment, or we can discuss later? Okay, so it looks like we have no burning comments, so I can proceed. I can say, and I hope we will discuss that, but I'd like to see this diversity. I think we can go back to that during my presentation. I will just now ask to have my slides back. Thank you very much. And I will make some comments about renal insufficiency. I go back to Garfield, the registry that I introduced earlier on. Garfield also looked into patients with moderate to severe chronic kidney disease. And what the study reminds us, of course, this is not a novel information, but it is an important confirmation. If you compare the outcomes in patients with moderate to severe chronic kidney disease and venous thromboembolism with those patients with venous thromboembolism and normal to mild chronic kidney disease, you see that the outcomes are significantly increased in the former group, moderate to severe chronic kidney disease, with higher mortality rates, which are almost double. Higher risk of recurrent VT. This has to be kept in mind, and as expected, probably more than the increased risk of recurrent VT, an increased risk of major bleeding. So these patients are more complicated, are more fragile, but we have to keep in mind that their risk is increased for both recurrence and major bleeding. I will not comment the other variables, but this has to be kept in mind. Now, in the clinical trials, the phase 3 clinical trials on comparing the direct oral anticoagulants with vitamin K antagonists, creatinine clearance below 30 was an exclusion criterion. So we have patients with creatinine clearance between 30 and 49, the moderate renal insufficiency, and we do have patients with creatinine clearance of 50 milliliters per minute or more. In the meta-analysis of the trials, one of these meta-analyses, you can see that the benefits in terms of prevention of recurrence of the direct oral anticoagulants is maintained in patients with moderate renal dysfunction, moderate renal insufficiency, and what is even more important is also the benefits in preventing major bleeding events during treatment is maintained. So as you can appreciate, the reduction in major bleeding events with the DOACs is maintained also in patients with moderate renal insufficiency. And of course, this is a very reassuring information. We do have a subgroup analysis from one of these studies, the Amplify, where apixaban was compared with enoxaparin and warfarin, and you see here for recurrent venous thromboembolism, the benefits of apixaban is maintained. These studies show non-inferiority of apixaban in terms of recurrence, but you see that this non-inferiority is absolutely maintained at all levels of renal dysfunction. The study also shows superiority of apixaban as compared to standard of treatment in terms of major bleeding, and this was also maintained in the subgroups with severe or moderate. Of course, a large majority of patients had moderate renal insufficiency. You see there is still a trend which loses statistical significance, but is still quite clear in favor of apixaban. So this is absolutely reassuring. What happens in clinical practice in terms of prescription according to renal dysfunction? This is another registry, recovery, looking at the use of the direct anticoagulants in patients with venous thromboembolism according to the degree of renal insufficiency. And you see that the proportion of patients receiving direct anticoagulants remains quite stable until 30, and below 30, the proportion of patients is reduced to about 25%. But still, we have to look at also on the other side, and from the other perspective, there are still 25% of patients who did receive in the so-called real-world clinical practice direct anticoagulants despite renal dysfunction with recurrent clearance below 30, which of course is possible, as we've seen for all DOACs until 15 of creatinine clearance, with the exception of the bigatron. And these are the dosing regimens for apixaban. There are no dose adjustments recommended on the caution between 15 and 29. Dose reduction is only suggested for patients with taking rivaroxaban that has a higher elimination from the kidney, but not recommended. So this is something we can consider. The same for the bigatron, reducing to 110 milligrams. For edoxaban, the dose reduction is actually recommended. So you have to use the lower dose, 30 milligram dose, in patients with moderate or severe renal impairment. So there are some differences from not necessary to reduce the dose for apixaban to mandatory to reduce the dose for edoxaban. Another challenging situation is represented by high body weight. So now let's think Mary as an obese patient. So Mary comes, she has again her same symptoms. She has hypertension. She's diagnosed with proximal deep vein thrombosis, and she is obese with a body weight of 120 kilograms. This is also challenging, and this is my second polling question. So what if Mary had a high and actually very high body weight? Again, your answers: I would not change my therapeutic strategy, prescribing direct anticoagulants at the standard dose. Can you trust the direct anticoagulants in a patient with this body weight? The second answer is I would prescribe some direct anticoagulants only, for example, apixaban or rivaroxaban, based on available evidence. The third answer is I would prescribe unfractionated heparin and warfarin because I can monitor the effect of these drugs. And so if there is any effect of body weight, I can make sure that I will adjust the dose of the drug accordingly. Answer D, low molecular weight heparin and warfarin. So please vote, and we will see in a few seconds your answers and see if there is again some difference in your answer, sure you're more uh, homogeneous, which again is good for our subsequent discussion because these are challenges that we can face. I know in Eastern Asia, Far East is definitely not an issue as much as in the United States and to a lesser extent in Europe, but still you can face these patients sometimes, or you can have an American tourist who is diagnosed in your hospital. Okay, so not too different from the previous poll, which is interesting. Thank you very much for answering. So again, the majority which corresponds to half of the respondents, would not change therapeutic strategy, would rely on the direct anticoagulant. 1/3 would actually select two only of these anticoagulants, apixaban or rivaroxaban. I would say the minority would select unfractionated heparin and warfarin, a few more low-molecular heparin and warfarin. So again, I asked the panelists if they do have any comment they want to make now, or there will be opportunity to discuss at the end of my talk. We will certainly have time. Any burning comments from you? Not yet. So please let me discuss the evidence, not that much evidence, but the evidence that we do have on obese patients. If I can have back my slides, I will discuss with you what we do have, because of course this is an issue, certainly more in some areas of the world, as I mentioned, but it's not so easy to trust on a drug that cannot be directly, I mean, it could be potentially measured, but of course we don't have the same accuracy in the, of course, standard of treatment remains a possible alternative. We have completed our first 3 months of treatment for Mary, and now we have the final question. So Mary has gone back to her original version, so she is, her body weight is 71 and creatinine clear is 61, and now we have to decide what to do. So Mary is doing well, and the question is, should we continue Mary on treatment or should we stop treatment? So this is the final phase, which refers to the secondary prevention of venous thromboembolism. And the guidelines, I'm quoting here the American Society of Hematology guidelines, but all the other guidelines are in the same ballpark, suggest or recommend to stop treatment in case of VTE provoked by temporary risk factors, suggest to continue indefinitely, and so to reassess periodically, but to continue unless contraindications come up, in case of unprovoked venous thromboembolism, and if there is a provoking factor that is considered to be chronic, indefinite treatment is also suggested. So Mary has an unprovoked event, and so according to guidelines, she should continue treatment. Now, the second question is, shall we rely on a reduced dose of direct anticoagulant, or shall we continue with the same dose that she received in the first 3 months of treatment? The European Society of Cardiology suggests to reduce the dose of the apixaban or rivaroxaban after 6 months of therapeutic anticoagulation. The American Society of Hematology suggests using either standard or a lower dose. So the decision is left to the treating physician, no preference. The American College of Chest Physicians suggests the reduction for apixaban or rivaroxaban and over, of course, the full dose of these drugs. So some minor discrepancy among these guidelines, but overall, dose reduction is suggested. As you may recall, we do have some phase 3 clinical trials that assess the direct anticoagulants for the extended secondary prevention of venous thromboembolism. And in two of these trials, Einstein choice for rivaroxaban and in the Amplify extension, compared with the standard dose of rivaroxaban and aspirin in the Einstein choice study. All other studies compare the standard dose with placebo, the bigatron racemate and Einstein extension rivaroxaban, or the bigatron with warfarin. Dose reduction, the studies were positive. The reduced dose may occurrence of bleeding events. I think this slide speaks better than any other graph, because if you look at the number needed to treat to prevent one recurrent VTE, the apixaban to cause a major or a clinically relevant no major bleeding events, as compared to 63 patients with apixaban 5 milligrams. So there is a clear advantage where in terms of safety, whereas for extension were confirmed by a recently published Apidulcis study, which is actually a management study which includes the use of a D-dimer to select patients who can safely stop or continue anticoagulation based on the results of D-dimer. Those patients who had positive D-dimer were all treated with low dose apixaban. So we do have a further test in a more general population, less selected population in this management study. And of course, low dose apixaban in those patients with positive D-dimer was compared with no treatment in patients with negative D-dimer. In this Apidulcis study, you see that the result support continuing with the apixaban, because those patients who stopped because of negative D-dimer actually had a non-negligible recurrence rate for VTE, and they were well protected with the use of low-dose apixaban. But what is more important is that the incidence of major bleeding was exactly the same in patients receiving low-dose apixaban and receiving no treatment. So again, very reassuring results. So this is my last slide, dear colleagues, ladies and gentlemen. What about Mary then? So she had unprovoked deep vein thrombosis and a low bleeding risk. So she definitely continued on the standard dose of the direct anticoagulant for 6 months. And then she received a reduced dose DOAC. And the aim was to treat her indefinitely. Of course, she will need to be periodically reassessed. If Mary had moderate renal insufficiency, I would have used the same approach. I would have increased the control of renal function during her follow-up, and I would have favored a direct anticoagulant with a lower rate of renal excretion, which would have resulted in probably safer choice. If she had a high body weight, I would have used apixaban or rivaroxaban based on the results that we had. And so thank you very much for your attention. Now, I very happy to discuss. I think Sidamed, you will chair the discussion with all the panelists, and thank you again.
Thank you, Dr. Agino, for this very nice overview and sharing with us the challenging scenarios. So let's move now to the Q&A. We have received some questions from the audience. The first one is a patient with stable CAD and DVT. Is the treatment only with DOAC without antiplatelet? Is there any study regarding this? Oh, Dr. Ageno, our esteemed panelists, if you can take this one.
Wait, this is a very interesting question. So the patient has a stable coronary artery disease and a history of venous thromboembolism. So the evidence, so for this patient, the first question, in my opinion, is whether the patient requires extended indefinite secondary prevention of venous thromboembolism, or the patient can stop venous thromboembolism. Because if the patient can stop, the patient might be eligible for low dose, very low dose rivaroxaban and aspirin. This is an opportunity which would not be used for the prevention of VTE, to make it clear, but as it emerged from the COMPASS study, this could be an option. If the patient, of course, may continue on aspirin. If the patient should consider better prevention of both coronary artery disease and recurrent VTE, this is an option. We do have evidence that anticoagulants alone may be also effective in preventing. Of course, I would use a full dose in this case. This was already clear from warfarin studies showing that warfarin could have been effective in preventing recurrent coronary artery disease. There is less evidence with the directional anticoagulant, so keeping aspirin effective. But of course, I leave it to the panelists to see what is their opinion. I think there is one cardiologist in the panel. So
yeah, we have cardiology, hematologist. So who's like start first? Cardiologist, maybe.
Yes. If the patient has a stable treatment, so I think I would be much would I would feel it's safer for the patient to give the anticoagulant full dose, but shift the aspirin to clopidogrel. Might less.
From the other panelists.
Thank you, Dr. Junior. I'm Dr. Huang from Hong Kong. So you mean during the period full dose?
Yes, and full dose, because it's especially
Or
might be less. Is with if we need the NOAA and then they had a stent, or the recommendation is more for either aspirin or clopidogrel, but for most patients, preferably clopidogrel.
Yeah,
Yes,
I always find it when patients ask me, I'm on aspirin or I'm on clopidogrel, I'm going for surgery, what's my risk of bleeding? I always look at them and say that I'm not sure. So in the same way, we really add on the antiplatelet agent with, in this case, NOACs, the risk is, of course, there has to be an increase in risk. I don't know how to quantitate it, honestly. We'll be interested to listen to our esteemed panelists or speaker, what's their view, because it's always difficult to quantitate the bleeding diastasis or bleeding risk of aspirin, be it aspirin or clopidogrel. That's my view.
DVT aspirin is allowed in the clinical trial, but I think clopidogrel is not allowed in patients who are on DOACs.
Thank you. So we have, of course, the opportunity to submit questions for our audience. So please don't hesitate. You have the chat box. Just submit your question with the lower extremity DVT and PE for the indefinite anticoagulation. In what circumstances would you perform a routine imaging to facilitate routine decision? So the selection criteria to go indefinite, and the imaging, the role of imaging, or to decide about your treatment. Maybe from the hematologists who are here and the panelists can hear from them about that.
You want me to start? I don't know if it was the question for the panelists, I think, or
yeah, of course. What as Doctor, as you know, you can also, if you want to have a comment on this about this, the criteria to say the selection for the going for the indefinite, the extended treatment, and the role of imaging, the routine.
Yeah, I can just say a word about the role of imaging because I think I mentioned the rest earlier on. It's an interesting question because we do have evidence that residual vein obstruction measure within 3 months is associated with an increased risk of recurrence, although the magnitude of this association is not that relevant. So there is about 30% increase. So in some models, you may also include residual vein obstruction, but what the study has shown us is that if this is measured after 3 months, at 6 or 12 or later, it was not to rely on residual vein obstruction.
So, Dr. Ajeno, I'd just like to ask if so there is no point, no value. Is there a quantification of after 3 months?
Criteria were really based on the measure of the thrombus in millimeters. And others. So it was a person, but some residual obstruction was associated with if residual obstruction is not considered useful to predict the risk of recurrence. In my practice, at the time when I decide to stop or not stop treatment, I always take a measure. I repeat ultrasound, in particular for those patients who will stop, because this gives me a sort of baseline. Why I do repeat the ultrasound is mainly to have a sort of baseline information that allows me to make comparison between the two imaging studies. Because sometimes detecting recurrence, especially in those patients who still are obstructed, is not easy. And there is a chance that you may call as a recurrence something that is an old clot. And an experienced echographist may be quite good at distinguishing these, but this is not always the case.
Do you also include the D-dimer?
measuring for assessing recurrence, yes, this is absolutely correct.
But if you plan to continue anticoagulant long term anyway, so do you perform the dimer?
No.
No.
I'm talking about the patient who's off treatment and comes back for recurrence. Although it's interesting, in the Apidulci study, the proportion of patients with positive D-dimer on apixaban was higher than expected. So what the effect of the direct anticoagulants on D-dimer seems to be different from the effect of warfarin, but this is something we need to better understand.
Sida, may I ask a question? Because
Yeah, of course. Please go ahead.
yeah, we presented the scenario about the 120 kilograms, but I think we also we're not really mainly affected by that scenario, but we have the low body weight patients. So should we use full dose on these patients, or is there, because the studies don't have the reduction in dose with very low body weight patients?
This is an excellent question, and I fully appreciate that your problem is mainly with low body weights than we do have with high body weights. But I think we have the same kind of issues with the evidence, because, of course, many of these patients were with extremely low body weights were not included in the studies. What we do have also from the data that I show you, which also included some extremes on the other side, is that there seem not to be an excess of events on direct or anticoagulant as soon as possible. Maybe not in the first weeks, though. But I know in some Asian countries they do have some recommendations for using the lower doses. And I'm really concerned when body weight is below 40, between 40 and 50. I'm not that concerned, but below 40 I am. Of course, warfarin can be measured and can be monitored, but the benefit doesn't seem to be there in terms of efficacy and safety. So the question is,
Thank you.
Okay, thank you.
Any final burning comment or question before closing, because we're almost on time?
Could I ask
Yeah.
the speaker, in the latest ASH recommendation 2020, if it's unprovoked kind of situation, the patient will get the indefinite second episode. So we are in a situation that we may end up with a lot of patients going to fall into the drain, the kind of situation that everybody is safe taking anticoagulant, or what's your take?
I like this question. This is excellent, because you're right. I think with the new 2004, when we had some ACCP guidelines, and you compare these with guidelines that came out after 2015, the proportion of patients requiring indefinite treatment increases from about 30% to more than 60%, so more than double. So this is absolutely true, and this is based on the fact that with vitamin K, approach that takes most patients, unfortunately, with definite treatment. But I think we need to be doctors. We need to carefully assess each patient, carefully assess the bleeding risk. And especially for young patients, I think we still need to have some prognostic models that may help us to understand if there are some patients who may safely stop treatment. D-dimer was a possibility. Probably D-dimer alone doesn't work enough. It does tell us something, but it's probably not enough. And then you can add D-dimer in some models like proposed in the ERDU2 or Vienna score. But I think there is still work to be done, because I also feel quite frustrated when I had to tell to a 30-year-old patient or even younger that he or she will stay on treatment forever. This is quite frustrating for me.
Thank you. Thank you, Dr. Ageno. Thank you, Dr. Alex, Dr. Sushi, Dr. Pantep, and Dr. Gloria, for your time today. This is the end of our live webinar. Before leaving, please provide us with your comments through the survey button. You find the green button survey. Click on it and provide us with your feedback. We want to do better, of course, based on feedback in the future. And without further ado, would like to thank you all and wish you a good evening. Thank you. Bye-bye.
you